Hello everyone, we're here to talk about the correct way to perform a CIWA. We use the CIWA AR, Clinical Institute Withdrawal Assessment for Alcohol. This is about performing the assessment here at Piedmont Medical Center. Useful information. Withdrawal from alcohol typically begins 48 hours after the patient's last drink. Withdrawal usually lasts anywhere from 3 to 5 days. Performing the CIWA assessment correctly is essential for proper treatment. Piedmont Medical Center has levels 1, 2, and 3 for alcohol withdrawal protocols, and each level is a little bit different on how the treatment is given to the patient. So you need to make sure that you do a correct CIWA evaluation every time on your patient. First thing you do is vital signs. These are always objective. Date, time performed, temperature, pulse, respirations, blood pressure, and O2 sats. The first section that you see on your CIWA will be nausea and vomiting. I look at this one as both subjective and objective. Subjective, of course, what the patient tells you. This is always the most important. So you ask them, are they feeling sick to their stomach or have they vomited? If they respond yes, have them rate this on a 0 to 7 scale. So basically you're going to say 0 is no nausea or vomiting and 7 is the worst you've ever seen. And they're going to rate it in between. And you're going to use that and compare that to what you observe. So the objective part, what you observe, is important. For example, patients sometimes exaggerate where they're really at. Some may be drug seeking. I mean, you have to keep all this in mind. So if the patient rates the nausea and vomiting at a 5 out of 7, if you look down at 5, you see that 5 is moderate to intermittent possible dry heaves with at least 4 to 7 times observed by you. Is this what you're seeing? Are they dry heaving or vomiting? And can you match it up to where they rate their difficulties? If not, then I need you to look at this another way and say, okay, let's just call it a moderate or whatever, but give them the correct score so that you know that you're scoring them on a good basis. Tremors. These are objective only. This is not the patient saying, yes, I shake. This is not the patient saying, oh, I just feel shaky. You need to do the assessment. Make sure the patient's arms are extended and the fingertips are spread apart. You touch the fingers and you feel for a tremor. So even if you can't see one, sometimes you do feel one, and this is called an essential tremor. Make sure you feel their fingertips. Give them water in a cup. Watch them try to drink it. Sometimes you can see shaking in the hands. It might be mild, but it is observable. Have the patient stick out their tongue and look for tremors the same way. You'll see the tongue shake anytime that they're going through any kind of withdrawals. On the scale, 1 is not visible but felt in the fingertips. This is your essential tremor. This is why you have to touch your patient. Arms extended, fingertips stretched apart. 2 is visible in the fingertip or tongue, which means that you can see the shake. 3, then this is using a drink. Bring the drink to the mouth and a tremor seen, of course. 4, seen with arms and fingers extended. So basically you say hold your arms out, but you just see the shake. You don't even have to touch them. 5, they take 2 hands to bring a cup to their mouth. 6 is they bring the cup up, but the liquid that's inside spills out because they're shaking so badly. And 7 is very rarely seen. It's severe, but they have difficulty standing unassisted. They're shaking all over. These are the kind of things that you would see with severe withdrawals. Paroxysmal sweats. When we ask you to assess for paroxysmal sweats, we need you to check the patient's palms, the back of the neck, and the forehead. These are areas of where you will feel any kind of perspiration on the patient. So if you look at 0 is always none on all of these. So 1, palms are moist, barely perceptible. It means you can barely feel anything. 2, palms and forehead moist, but it's difficult to see. 3, barely can see sweat on the forehead or the palms. 4, you can see the sweat on the forehead. 5, the sweat is very visible. The patient's clammy all over. You got a clammy feel to the skin. 6 will be their bedding and clothing are a little wet, and 7 is where it's all drenched. So tactile disturbances, FYI, numbness, tingling. These symptoms typically begin 24 hours after a patient's last drink and normally occur in the fingers, the toes, the forearms, and the calves. Objectively, are they rubbing the skin? What do you see them doing? Are they scratching the back of their head, rubbing their head constantly? If you see this, then they're obviously having some disturbances. Subjectively, which is at the bottom, ask them if they have itching, burning, numbness, or feel something crawling on the skin. If they say yes, have them rate this 0 to 7. What you see, what they rate, need to kind of be combined. You're making a clinical decision here when you use your judgment with theirs, and you can see where they're actually at. 1 is very mild, 2 is mild, 3 is moderate, 4 is moderate to severe. With 4, you're going to see a lot more frequent scratching and rubbing of the heads. Severe, this is where they become restless, they toss, they turn. Maybe they're rubbing their legs together up and down in the bed. They just can't seem to get comfortable or stop moving. Extremely severe, this is difficulty sitting or even laying due to this sensation on their skin. And 7 is continuous. The skin is crawling, they feel almost like bugs sometimes, can't sit still, they're restless, they're irritated. It's very rare to get to that level. Just be sure that you are assessing correctly. What do you see versus what they say, and make the judgment on where they're at. Auditory visual hallucinations. Same here. Auditory hallucinations are rare, especially in treated alcohol withdrawal. So patients can still see some irritation or have some irritation from loud noises or loud voices outside in the hall. It can easily set them off. And visual hallucinations, typically these are more along the lines of irritability to loud lights. I guess you see too many bright lights, or that causes pain to the eyes and stuff, so they get more irritable. In auditory, ask them if they're hearing things that are not there, if it scares them, if they're bothered by the noise, and how bad. Again, you're going to use your scale, have them rate this 0 to 7. You don't tell them everything in the scale. You just say 0 being none and 7 being the worst you've ever had, and they will rate in the middle somewhere and tell you what it is. Same thing with visual. Ask if the lights are too bright or if their eyes hurt, if they see things that aren't there. And then if they say yes again, you're going to ask them how bad, have them rate this. Anxiety, subjective and objective. Subjectively, you're going to ask if they feel nervous, uptight, have them rate that again. Remember, it's on the scale, so you're going to say with 0 being none and 7 being the worst anxiety you ever had, and see where they go in between. Objectively, do you see what they're rating? Do you see them pacing, moving a lot, shaking the legs, tapping the hands, inability to just be calm? On the scale, 0 to 3 would be considered either none, of course is 0, mild is 1, 2, and 3. On the scale, 4 to 6 are considered moderate, moderate to severe, severe, and 7 is like a full-blown panic attack. You can't miss the one with 7. You will know if they have reached a level 7. Agitation, again, subjective and objective. You'll see irritability, inability to sit still, tossing, turning, constant movement, or lying and sitting. So on the scale, there's 0 with none, 1, a little more than normal activity, 2, mild, they're very restless, 3, moderate, they're fidgety, they're restless, more difficulty sitting still, 4, moderate to severe, they visibly can't sit still, they're in and out of bed, they lay, then they sit, and they're just up and down, up and down. 5, severe, worsening movements, inability to sit still, can't get comfortable, they're very snappy, they're easily set off. 6, severe to extreme, movements for them are almost constant, they may get up, down, they may be pacing, they may be yelling, sometimes cursing. And extreme, this is a constant pacing back and forth, they thrash about in bed, you will definitely know if they reach the level 7 because the thrashing is evident. Headaches, fullness in the head. FYI, this is common as your intoxication decreases. We all know this as a hangover. So these patients can also have some nausea. So this is a subjective assessment. You're going to ask the patient if the head hurts, if the head feels different. Maybe they feel a band around the head, or there's some dizziness or lightheadedness that they may report. And again, none at all, and 7 being the worst they ever felt. You're going to have them rate this on the scale, and then you're going to chart that. And with your orientation, clouded sensory, this is also subjective. You're going to ask the patient the questions. Can you tell me what day of the week it is? Can you tell me the actual date, the month, and the year? Can you tell me where you're at? If they don't know where they are, that may be a little sign that something's going on. Can they count backwards from 20 by 3? Or can they do 2 plus 2, 3 plus 7, 5 plus 1? These are simple mathematics. If they can't perform these, then perhaps something is wrong. Keep in mind, if you have given the patient some Ativan because they're in withdrawals and you're doing another CIWA score on them and you get to the orientation piece, you need to make sure that you understand you gave them Ativan, so their answers might be a little off. So just keep in mind if they have been sedated or not prior to your assessment. Follow the scale. 0 is oriented with some addition or serial 3s. 1, they can't tell you the date or they're not sure, can't do serial 3s. 2, they're disoriented by 2 days at least. 3 is 2 days or more, and 4 is disoriented to person, place, situation. So with this in mind, this is how you do a CIWA. I hope it helped. I hope the tips I added can make it easier for you to perform this assessment. It's very hard to go in and do these, and when you just ask the patient the questions and you go off of what the patient says, the score can be astronomically off the chart. If you go off of what the patient says combined with what you see, then you're going to be able to more correctly assess your patients for a CIWA withdrawal. Thank you.
Now that we have learned how to properly assess for alcohol withdrawal symptoms, we need to discuss the critical decision point that needs to be made in the emergency department. The critical decision point is, does this patient require a hospital admission to manage their withdrawal symptoms? Your CIWA assessment score aids in that decision by scoring the severity of withdrawal symptoms. For CIWA scores from 0 to 10, the patient is treated prophylactically and can be managed in the emergency department with PRN Ativan or Librium. For scores greater than 10, a hospital admission is indicated, and the ED provider should be notified of your assessment results. As the CIWA assessment includes subjectivity and objective judgments, the ED provider may assess the severity of symptoms different than you do. The ED provider will assess the patient and make the determination whether or not to move forward with a hospital admission. The other critical point to be made in the emergency department is when to initiate CIWA assessments and treatments. You do not need a physician order to assess your patient for withdrawal symptoms. If you know your patient has a history of daily drinking or abusing benzos, or test positive for alcohol or benzos, be proactive and initiate assessments. A patient with a long-standing history of abuse may begin showing withdrawal symptoms quicker as they metabolize. If your patient begins showing withdrawal symptoms, ask the ED provider to reassess the patient and or ask for a CIWA Level 1 order set so you can treat with PRN Ativan. PRN Ativan is typically administered with CIWA scores 8 to 10. At any point your assessment score goes above 10, again, notify the ED provider of a potential hospital admission. Finally, Piedmont Medical Center's alcohol and benzodiazepine withdrawal assessment and treatment guidelines policy is located in the MCN policy database. Per policy, Each level of CIWA severity has its own treatment order set. Level 1 is prophylaxis for scores 0 to 10. Level 2 is medical admission for scores 11 to 25. And Level 3 is ICU admission for scores greater than 25. Each of these order sets can be initiated in the ED. If you have any further questions regarding CIWA assessments and treatments, please contact ED management. Thank you.